pretty big topic. So I figured, I know that you guys all like to look at EKGs, and I've noticed some of you are pretty good at reading EKGs, so I thought maybe we'll just do the EKG part of VTAC in terms of diagnosing VTAC, discriminating between ventricular tachycardia versus SVT with aberrant conduction. Because, you know, it's kind of important to diagnose that, and that's something that you guys do all the time. So, you know, just to get sort of bread and butter stuff out of the way, VTAC obviously is a rhythm that's originating from the ventricles, not involving the AV node or the atria. And if it's over 100 or 120 beats per minute, in some people it's called VTAC. If it's less than that, it's accelerated idioventricular rhythm. It's just basically based on the rate. AIBR is generally benign. People don't die from it, and it can be. You see it quite a lot in reperfusion arrhythmia after an MI. People have had a stent for a STEMI and they come to the ICU. You'll see reperfusion arrhythmias in the first 48 hours. They don't necessarily predict death long term, and we don't use that as an indication for a defibrillator. After 48 hours, up to 10 days, you're building your chronic substrate for arrhythmia. You've got a scar that's developing. And so arrhythmias that typically happen, like sustained VTAC happening greater than 48 hours after an MI, that usually means you've got a circuit. You've now grown a circuit. You're going to have problems with VTAC down the line, and that would be an indication for us to do something about it. Most ventricular arrhythmias you're going to see are scar-related from ischemic heart disease or from idiopathic cardiomyopathy. So most of them are going to be monomorphic. Monomorphic means you've got a circuit. Now the circuit could be physical, like you've got a fixed scar, and that circuit goes around the scar, or it could be functional reentry. So you don't actually have a fixed scar, but you have areas of slow conduction. And when you send off a PAC or PVC, those areas of slow conduction become like their block. They can't conduct that fast. So they act like a scar, and you get reentry around an area of functional block. And because the electrical circuit is reentering all the time, it keeps it blocked. So basically, reentry means a circuit, and that's what most monomorphic arrhythmias are. And we call it sustained if it's greater than 30 seconds. So it's this indications for us to do something long-term, like they need potentially an ablation, they may need a defibrillator, is sustained ventricular tachycardia or hemodynamically significant ventricular tachycardia. So if we see somebody who's got chronic coronary artery disease, comes in with pneumonia, and they have non-sustained runs of ventricular tachycardia, they might be symptomatic. We might treat them for symptomatic purposes, but they're not going to get a defibrillator. They'll get a defibrillator if they crash and you pulseless and you have to shock them faster than 30 seconds or as fast as you can. Or if it sustains for more than 30 seconds, you've got to look at it. That could be long-term life-threatening problem. So the three mechanisms are reentry, triggered activity, and enhanced automaticity. Reentry is what you're going to see mostly if you see monomorphic sustained VTAC. And it might start because of triggered activity or enhanced automaticity. So reentry means there's a scar, either fixed or functional. Triggered activity means you have an extra beat that's dependent on a previous beat. So an example of that would be long QT syndrome, where you get a sinus beat and you have a long QT, and that sets up an early after depolarization. In other words, the repolarization takes so long that you suddenly fire off another beat, and that can set up ventricular fibrillation or ventricular tachycardia. Another example of that would be hypokalemia. That would also be triggered activity. Digitalis toxicity or calcium overload is triggered activity. Enhanced automaticity is what you see with if you give somebody isoproterenol, epinephrine, catecholamines, they get sinus tachycardia. Firstly, that's the most normal kind of enhanced automaticity, but they can also get VTAC. Not that important to know. What is important is to be able to diagnose VTAC by the EKG and decide, is this VTAC or is this not VTach? So the key, honestly, is to look at the QRS and see if it looks like a typical right or left bundle. Because obviously if it looks like a normal QRS, you're not going to think it's VTach. You're going to say it's SVT or it's AFib or something like that. Although you could be wrong, but that's probably going to lead you to that direction. But when you see a fast, wide complex tachycardia, that's either VTach or it's SVT with aberrant conduction. So by aberrant conduction, we mean a right bundle branch block or left bundle branch block. And when you have monomorphic VT, it sometimes resembles a left bundle or it resembles a right bundle. So I'll show you a bunch of criteria to diagnose VT. But there are two key things. The first thing is AV dissociation. If there are more V's than A's, it's VTach or a ventricular arrhythmia, right? Has to be. If you see that, you don't even have to look at the morphology. This is a ventricular arrhythmia. If you can't see P waves, which you often cannot, then you've got to look at the QRS morphology. That's where it gets a little bit more difficult. And then I'll show you the criteria to look at. But the key thing to remember is, does it look like a typical right bundle or a typical left bundle, or does it not look like a typical right or left bundle? That's all the criteria are telling you. If you have somebody who's had a prior MI and has an ischemic cardiomyopathy with a low ejection fraction, previous MI, and they have wide complex tachy, and you just close your eyes, you don't look at the EKG and you say it's VTach, you'll be right 80% of the time. So if somebody with ischemic cardiomyopathy has wide complex tachy, you've got to prove to yourself it's not VTach, because it probably is. And remember, young guy, bizarre looking QRS, irregular wide complex rhythm, it's probably WPW with AFib. So here's an example of AV dissociation. Here's a little run of VTach, and you can see, let me get my pointer. There it is. So here's sinus rhythm, P wave. P wave looks like he's got a kind of a Q wave here. Maybe he's had an infarct before, he's got a little ST elevation. Maybe he's got a ventricular aneurysm. And then he, has a run of monomorphic VT. And you can see the P wave there, P wave there. This P wave here falls in the QRS, you don't see it. That one falls just after the QRS. And then this one comes, doesn't conduct, because you've got retrograde conduction from this QRS here blocking, making the AV node refractory. So it doesn't conduct, and then you have the next P wave. So that's AV dissociation, diagnostic. This cannot be SVT with aberrant conduction, this is VTach. Another example of that is capture beats. So here you have VTach, and in the middle of it you have an early beat that's actually narrow. How do you explain that? Anybody have an idea? Well, remember from the previous one, you have sinus rhythm going on in the background. And it doesn't conduct because you've got all those QRSs that are hitting the sinus node retrograde and keeping it refractory. And once in a while, one of those sinus beats will come down the His bundle and find the bundle branches not refractory, and then it conducts. So you have a normal QRS that conducts by chance. You see there's a little P wave there, and then a QRS. And there's just a little gap it happens to get through. Those are capture beats. So if you see capture beats, that's the equivalent of AV dissociation, it's VTach.
Can't see your pointer.
Oh. Can you see it?
You won't be able to see it in the PowerPoint presentation mode.
Oh, really?
Yeah, you'll have to do the old-fashioned use your finger to point.
Oh, okay.
Yeah.
Well, let me do that again. P wave here, P wave there. You see that one? And this one you don't see because it's buried in the QRS. Then you have this one here, and then that one that doesn't conduct. So, everybody see that? AV dissociation, more V's than A's. If you have more A's than V's, that could be a number of things. It's likely that it's atrial flutter or atrial tachycardia with variable conduction to the ventricle. So for example, atrial flutter, variable conduction with the left bundle branch block. You'll have AV dissociation, but there are more A's than V's. Now it's possible that you actually have complete AV block and you have atrial flutter and VTach at the same time, and arc block. But then you've got all three things you've got to explain. probably know, because somebody like that would have a pacemaker and a history of AV block, which would make you wonder how they can have quite a complex tank. So here's the capture beat. You can see a little P wave there. There's a P wave there. Obviously it cannot conduct because this beat of ventricular tachycardia preempts it and makes the AV node refractory. Then that P wave comes, and it just happens to come after bundle branches have ceased being refractory, and it conducts. And then that P wave doesn't conduct because you've got the QRS, same here. And then this one you can't see, it's probably buried in here somewhere, happens to conduct. Same with that one and so forth. Everybody see that? Capture beats. So that's diagnostic of VT. Here's another thing that'll make you think that, that you have VT. This is probably somebody with a scar. And they have fixed coupled PVCs. You see here's a QRS, and there's a certain amount of time you get a PVC. QRS about the same. If you measure from here to here, and from here to here, it's about the same time, and it's very close to the cycle length of the ventricular tachycardia. And the reason for that is there's a circuit, and it takes a certain amount of time to get through that circuit. And that's why you have these fixed coupled beats. Sometimes the coupling interval will be slightly different when it's just a PVC versus VT, because the circuit can be just a little bit bigger when you're just getting the PVC. But when you see PVCs with the same morphology as the VTAC, then this tells you this is VTAC, it's not aberrant conduction. Another clue. So we talked about re-entry, and this is just an example of what we mean by re-entry in a scar. You can imagine this is a chunk of cardiac meat, and the patient's had an infarction, and this is dead. Dead tissue here, dead tissue there. This here is diseased myocardium that survives, but it conducts very slowly. So you get a wave of depolarization, enters the scar area, and travels very slowly through here. By the time it gets out here, the ventricle's not refractory anymore, and it captures the ventricle. And then the electrical signal goes around, comes back in. And now you've got this circuit of ventricular tachycardia going around this area of scar. So that's what we mean by re-entry. And here you see the same thing with the area of scar, and that scar can be fixed, a permanent scar, or it could just be an area of extremely slow conduction that acts like a scar. There was something else on that slide. This is the next slide. Okay, so sometimes you can tell things from the VTAC. So for example, this is somebody who's had an inferior MI, and they've got an inferior scar, but they've got a right bundle branch block. And because of the right bundle branch block, you don't see the typical inferior Q waves you'd always see in somebody with an inferior scar. But when you go into VTAC, those Q waves appear. So you can see them here, 2, 3, and they don't show AVF. But so sometimes you can get an idea based on the morphology of the VTAC where the scar is. And even if you have a right bundle, you don't see the inferior scar, it can suddenly come out when you have VTAC. We get called about this a lot. Anybody, well, I've got the answer. Okay. That's not real VTAC, right? This is somebody shaking the ECG lead. The EP techs like to do this when they're pulling sheets in the EP lab. They say, oh, he's in VTAC. See if they can scare me. But you can usually tell it's VTAC. I mean, it's artifact, because you see other artifact at other places, right? If you see stuff like this, and then you see a run like this, be suspicious that it's artifact, because artifact usually is scattered all around, and you can tell that some of it's artifact. The way you know this is artifact is you can actually march through these QRSs in here. See that one, this one, and that one. So if you get your paper strip out or your calipers, and you march them through, you'll see that it's artifact. Same thing here. Here's the QRS. Here's the QRS. This is a little artifact here. QRS there, and there. So you'll see that a lot in the ICU. So if you start going to diagnosis of VT based on QRS morphology, it gets a lot more difficult. And you can be wrong, but we have Whelan's criteria and Brugada criteria, so I'll show both of them to you. But remember, the bottom line is, does it look like a typical right bundle or left bundle, or does it look atypical? And we'll show you examples of that. So the first part of the Whelan's criteria is to look at a typical right bundle versus an atypical. Let me see if I can show you. So here's a typical right bundle. Some of the older books talk about a good rabbit and a bad rabbit. And it's these little rabbit ears in lead V1. So a typical right bundle is RSR pattern. I'm sorry, but my family texted me early morning. Anyway, so the good rabbit, the little right ear, if he's looking at you, is small. The first ear is small and the second ear is big. If both ears are big, or if he has just one big ear, that's a bad rabbit. That's VTAC. So this is what a normal right bundle would look like, if you want to call a right bundle normal. Left bundle, you typically have a QS in V1, and then you have a big R wave in V6. And the other thing to remember, both are with right and left bundle, one ventricle is depolarizing quickly, and that's the first half of the EKG. The other half of the ventricle is depolarizing late, and that's the second half. So if you look at the left bundle, for example, right up there, you'll notice that the first part of the depolarization is really quick, and then the second half is kind of slurred. This is actually not that great of an example, because it's a little non-specific IDCD, but typical right and left bundle, the first half of the QRS is like a vertical line, and then the second half is kind of slurred. But with VT, the whole thing is slurred because it's all happening inside the ventricle. So again, right bundle branch block with a triphasic RSR, that's the good rabbit in V1, or a small QRS in V6 is probably aberrant conduction. So what he means by the small QRS in V6 is here, you get a little R wave and then a slurred S wave in V6, because that's right ventricular activation, left ventricular activation with the right bundle branch block. So really all he's telling you is that if it looks like a typical right bundle, it probably is. Monophasic R or biphasic QR or RS complexes suggest VT, that's the bad rabbit. Left bundle with a Q wave in V6 suggests VT. Remember, left bundle is typically a big old R wave in V6. So again, you're looking at something that's not a typical bundle. Prolongation of intrinsicoid deflection. That's the start of the QRS to the peak or the nadir. It has to happen quickly when it's bundle branch blocked. If it's slurred, it's VT. Right superior axis, especially if it's right bundle, kind of a northwest axis. So that would be if you're negative in the inferior leads, and you're also negative in lead B, standard lead 1, that would suggest VTAC. All right, very wide QRSs suggest VTAC. Brugada criteria are kind of similar. Again, just different ways of looking at, does it look like a typical right bundle or not? If you have an absence of an RS complex in any of the precordial leads, that's VTAC. So it's all Q waves, for example, or all R waves, that's abnormal. This is the same as the intrinsicoid deflection. If the RS nadir in any lead with an RS complex is greater than 100 milliseconds, that's VTAC. That basically says the beginning of the QRS is kind of slurred. I know you guys are glazing over, but I'll show you examples. Okay, so I showed you a typical left bundle and a typical right bundle. So now, here's something that's atypical. So here we have a VTAC. You look at V1, it looks like a right bundle patch, right? And this is the bad rabbit. You have a big old R wave. The first ear is much bigger than the second ear. And if you look at the beginning of the QRS, see how there's kind of a delay before it gets to the peak. So RS, you have a QS or RS in V6. Here you have an RS in this case, very wide and slurred. and just doesn't look like a typical right bundle. Here's the same thing here in V1 where you have one giant rabbit here. There's no RSR. So this is an example of a right bundle, something that looks like a right bundle that doesn't look like a typical right bundle, if that makes sense. So here's a left bundle on the left and a right bundle on the right. So here are the things that look abnormal on the right bundle. You've got basically a monophasic R. You don't have a good rabbit. You've got a delayed intrinsic coil deflection from the start to the peak. It takes a long time. Remember in a bundle branch block, one ventricle is activating quickly, whether it's the right or the left. When it takes so long to activate the ventricle, that's VTAC. Left bundle, look at this intrinsic coil delay from beginning to there. That's almost probably 160 milliseconds from beginning to the Q originator. And this notch in the downstroke is very typical of VTAC. You don't see that with bundle branch. So the key thing to remember is, does it look like a typical right bundle or not? That's all these criteria are telling you. Now, if you get aberrancy, why do you get aberrancy? Here's an example of aberrant conduction. You've got sinus rhythm, maybe a little bit of an incomplete right bundle to start with. And if you look at your refractory periods for the left bundle and right bundle is typically a little bit longer. So when you depolarize the ventricle and you depolarize the bundle branch, it takes a certain amount of time before those bundle branches are receptive to being depolarized again. They've got to restore themselves, and that's called the refractory period. So the right bundle is a bit longer. So here you get a PAC, and you got prolonged conduction through the AV node because it's stressing the AV node, and it arrives at the bundle, right and left bundles, after the left bundle's refractory period is finished, but the right bundle is still refractory, so you conduct with the right bundle branch block with a good rabbit, right? So if you have somebody in AFib and you have a long short complex, you'll often suddenly get a run, what looks like a run of non-sustained VT, or it could even be sustained. And that's not VT, that's aberrant conduction, what we call Ashman's phenomenon. And you typically see it if you get a long short complex, because these refractory periods are dynamic. They shorten as your heart rate goes faster, and they lengthen as your heart rate goes slower. So if you have a little pause, and then you get two beats really close to each other, you're likely to hit in the refractory period. So here's an example of AFib with aberrant conduction. If you look at the top there, you can see typical right bundle branch aberrancy. It looks like he's got an underlying left bundle, so this guy does have conduction system disease. But here he is long, short, and then you get the right bundle branch aberrancy. Does that make sense? No? Anybody not getting that? Stop me if I'm wrong. This is just an example of accelerated ventricular rhythm with retrograde atrial activation. Nothing really too interesting about that. Okay, we went through the Whelan's criteria. Now I'm going to have you test. Anybody want to say, is this aberrant SVT with aberrant conduction, or is this VTAC, and why?
Let me a minute.
Well, let's start here. Do you think, is it monomorphic and regular? Yes, it's monomorphic and regular. Do you think it's more like let's assume it's aberrant. If it's aberrant, would it be a left bundle or a right bundle?
I want to say right.
Right, and why did you say right?
Well, I'll be honest with you, I looked at the AVL,
Uh-huh.
and it looked very similar to a right bundle branch.
So now AVL, yeah, I guess you could, but AVL is not the one you want to look at.
I think
You usually want to look at V1 and V6.
Okay.
That's the key. So typically with a right bundle, you have RSR in V1 and RS in V6, right? And with a left bundle, you have a QS, like a big negative deflection in V1, and a big positive one in V6. So does this one fit for a right bundle? Do you have an RSR in V1 this over there? Pretty much not really, right? It doesn't fit well for a right bundle. Does it fit for a left bundle? Really doesn't look like a left bundle either. You've kind of got a QS up here, so maybe it's a left bundle, but there's no R wave here. So you're already thinking to yourself, this one doesn't really look like a right bundle or a left bundle, right? So remember, one of the Brugada criteria was a complete lack of RS in any precordial lead. Do you see any RS in any of these precordial leads? Pretty much not. Right? Is it very wide? Oh yeah, more than 160 milliseconds. So it's very wide. It's unlikely to be aberrant conduction. So we're voting VTAC. Anybody disagree with VTAC? Okay. VTAC is what it is. So remember, there's an absence of any RS in any of the precordial leads. That's one of the Brugada criteria. Intrinsic weight deflection is delayed, and that's both in Brugada and Whelan's criteria. You see what else? I don't see AV dissociation on this one, because I can't really see the P waves. But there might be. You know, this could be a P wave here, and here, and here, and maybe there, but I'm just not confident about that, so we'll leave that one alone. Okay, how about this one? Seth? I'll put you on the spot.
AFib with aberrance.
What kind of aberrance? Irregular wide complex rhythm. How old is he?
I can't see it.
Wolf Parkinson's wife.
17. That's it.
WPW.
WPW. AFib and WPW. Remember, young guy, AFib. This one is not such a bizarre looking QRS. You could think it's left bundle aberrancy, right? Because, you know, it's not very wide. It's kind of a QS and one and a big R wave here. So it doesn't look all that abnormal for left bundle. So you could be forgiven for saying AFib with left bundle aberrancy. But the 17-year-old should make you wonder, maybe it's WPW.
How often do you see that?
Well, I see it a lot more often than you do.
Well, yeah. Is it common?
They all come to me. Not that often.
Okay, I've never actually heard of a
Oh,
patient
excuse
with
me a
this,
second. Hello, I'm busy giving a lecture right now. But that's okay. It's all right. What can I do for you? Yes. Yeah. Should not be a problem. No, no, right.
Can you go back to that previous slide?
The WPW?
Yeah. I can't see that far away, but do you see a delta slur in there anywhere?
Well, remember the delta slur means that you're in sinus rhythm, and you've got competitive conduction between the accessory pathway and the AV node. So then you see the first part, you see the little slur, and then the rest of the QRS is skinny, right? So that's what that is. In this case, you're pretty much 100% going over the accessory pathway because there's no delay. You know, unlike sinus rhythm, you delay in the AV node, and then you get to this bundle. And you've got an accessory pathway, there's no delay. It just goes right there. So it beats the AV node every time. Now, you know, if for some reason you have a wimpy pathway and it kind of blocks, you may be able to go down the AV node. But in general, when you're in AFib with a slick pathway, you go down the pathway 100%, and it's all just wide. And you can kind of tell this is a pretty slick pathway because you look at the narrowest R2R in AFib. This is less than 400 milliseconds here, right? Less than 200 milliseconds. I mean, this from here to here is from this bar to that bar is 200 milliseconds. That's about what this is. So this would actually mean that it's a high-risk pathway that you should ablate it because you could die from this pathway. It's not likely, but there is a chance you could, especially a 17-year-old. Okay, how about this one? Anybody want to take this one? Beth?
Well, I don't have my glasses on. I really don't.
Okay.
It looks like VT to me.
Okay, why do you say it's VT?
Everything looks pretty monomorphic and.
Yeah, it's monomorphic. But it doesn't mean it's VT. Could be a flutter with a left bundle.
It is awfully regular.
Yeah, a flutter with a left bundle can be regular, it can be 2 to 1. So remember, there's the 2 ways. There's AV dissociation and there's morphology. The most important of them is AV dissociation. If you have that, you don't have to care about the morphology. So is there AV dissociation in this one? You'll need your glasses for that.
I do or don't?
You might need your glasses.
Okay.
But if you look here,
I'm seeing this.
there's a little P wave there. There's a little P wave there. This one falls in the QRS. There's the P wave there. There's the P wave there. You see the P waves marching through?
Mm-hmm.
So this is AV dissociation, more V's than A's. It's VTAC. You don't even really have to worry about morphology criteria. But if you want to go by morphology criteria, you can say it's a left bundle, right? Looking. And there's no big R wave here. In fact, there's hardly any R wave at all. There's no RS in any precordial lead. That's one of the Brugada criteria, right? Intrinsic weight deflection in this case isn't all that slow, as you would see, and it's not all that wide. So you could start thinking to yourself, well, maybe it isn't, maybe it's not VT. But the AV dissociation clinches it. All right. But just a reminder of the Brugada criteria there. All right, here you have another EKG. What's this one? VT or aberrancy? Anybody want to take it? So is it more like a right bundle looking thing or more like a left bundle looking thing?
Right bundle?
You're right. It looks more like a right bundle, right? And so does it look like a good rabbit or a bad rabbit in lead V1?
I think it's bad rabbit.
It is actually a bad rabbit, although you could say that it's RSR, so the first little ear is small. So it could be a good rabbit, but it's so incredibly wide. Remember, something right bundle more than 140 milliseconds. You don't typically see that with a right bundle. So if it starts getting real wide, you start worrying about VT. So this is actually indeed ventricular tachycardia. And mainly because it is so wide and so bizarre, it doesn't really look like a typical right bundle. What about this one?
VT.
Absolutely, this is VT. It's almost sinusoidal. If you look at this, it's hard for you to tell where does the QRS start and where does it end and where does the T wave begin. It's so wide that it's almost a sinusoidal rhythm. But, so it does have some RSs, right? There's RS. So it doesn't have that criteria. There are RS. But if you look, that was me. If you look at the RS nadir, R to S, that was one of the Whelan's criteria, Brugada criteria. Here you go. RS nadir interval greater than 100 milliseconds in any lead with an RS complex. So, yes, it's greater than 100 milliseconds by a lot. It's almost 200 milliseconds from here to there. Make sense? Very bizarre looking. Same kind of thing, right? Look at that. Really wide, almost sinusoidal. There's no way this looks like aberrant conduction.
This looks bad.
How about this one? Yeah, that is like death. That's a death. Yeah. EKG. You know, you can probably.
It's not
What
looking
about
compatible
this one?
with life.
Okay, Seth, I'll give you this one.
Say he's 20 years old.
20 years old.
I would call that SVT with a very
You know, that's a pretty good bet. Why did you say that? Huh?
It's an organized rhythm, it's regular,
Uh-huh.
it's got the RSR prime and V1.
Looks like a good rabbit in V1. So by morphology criteria, you're saying this looks like a typical right bundle. That's why you're saying it's SVT.
I wanted to say yes.
Yes. So I do agree with you. Morphologically, this looks like a right bundle branch block with a left anterior fascicular block, right? It looks like a good rabbit. It's relatively narrow. You've got the RS. Here you can really see how the first half of the QRS happens quickly, and the second half happens slowly, right? So you've got right ventricular activation quickly, and then left ventricular activation is a little bit later, right? So right bundle branch block, left anterior fascicular block, it looks narrow, but it's actually ventricular tachycardia. It's not SVT. Remember, the most important criteria is AV dissociation. Always look for that first. So if you look at this guy, you can see there's AV dissociation. Here it is. You wave here, you wave there, you wave there. See that? So this is actually a fascicular tachycardia. And so it's a rhythm within the conduction system, and it's coming from the left posterior fascicle, and that's why it looks like normal QRS. It looks like a right bundle with left anterior fascicular block because it's originating in the posterior fascicle. So it's not really common, and I'm just showing it to you as, you know, for curiosity and interest. But it originates in the left posterior fascicle, can occur in normal hearts. It's not deadly. It's a nuisance, and it can be incessant, lead to cardiomyopathy. And the treatment is really to ablate the posterior fascicle. That's what we usually do. Fixes it, but often calcium channel blockers like verapamil or diltiazem will suppress it. Did that help at all so far? Okay, what about this one? 25-year-old with palpitations, structurally normal heart. What is that? Is that VT or SVT with aberrants?
I'm just gonna say it's SVT with hair because of her age.
But it's VT.
Okay.
But so it's okay though. It's not deadly. You're not going to kill her by saying that. So she's in sinus rhythm, and you can see this QRS just starts in the middle of nowhere. There's a little bit of noise, but nice regular sinus rhythm. You got a capture beat, VT, and so what this is repetitive monomorphic ventricular tachycardia. It's left bundle branch block with an inferior axis. It's coming from the right ventricular outflow tract. It's really common. I see a lot of these in the clinic all the time. Often they're completely asymptomatic. They can be 25 years old and actually, like this young lady, have more VTAC than sinus beats. Completely asymptomatic. Athletes, they can be outstanding athletes. Typically when they exercise, they suppress this rhythm. And when they stop exercising, the rhythm comes back. Heart structurally normal EF, everything. I sometimes see them when they want to go into the Air Force or the Army or become a fireman or something. Oh, no, you're going to die, you can't be a fireman. And then you can ablate this and highly successfully, and then they don't have it anymore and they can go ahead and do their career.
Can I ask a question? If they're asymptomatic, why do you see them? Like, how do you even?
Because they want to become a pilot.
Oh, so
And they fail their flight medical because they're
Okay.
VT all the time.
Okay.
And I mean, sometimes, some people are asymptomatic, they can feel palpitations, and we see them that way. But a lot of them are completely asymptomatic, and we see them when they go, insurance medical, employment medical. Somebody gets an EKG, they go to nursing school, hook themselves up to the monitor. I'm dying.
So now you say you can fulfill your dreams of being a pilot.
Yes, they ablate them and they can go do it.
Okay.
So it's also known as Gallivardin's tachycardia. It comes from the right ventricular outflow tract, and the EKG is left bundle branch block inferior axis, and they have a structurally normal heart. Not associated with increased mortality. All right, last one. So this is a 24-year-old female, actually a triathlete. This is my patient. Went into top level triathlete, like international level competition. Went into VTAC after a triathlon. Thought she was dehydrated, kind of went to the medical tent and they gave her some fluids and everything, but they did a rhythm strip. There was an EMT, they did a rhythm strip that showed VTAC and then she went back to normal rhythm. And this is her EKG. Ring a bell with anybody? Any of our nurse practitioners have an idea?
I mean, it's sinus underlying.
Right.
You got a good rapid pattern V1, RSR prime.
Right, so it's kind of a right bundle branch block looking thing, right?
You know, call it
No.
PVCs.
And she's having these PVCs, right? So, you know, this is actually right ventricular dysplasia, arrhythmogenic right ventricular dysplasia. And that isn't really a right bundle, that's an epsilon wave. And you can see how fractionated it is here. It's very wide, the second part, and you have these big inverted T waves in these V1, V2, and V3. So that's it enlarged, and you can really see this fractionated thing. And if you see inverted T waves in V1 and V2 and V3, young person VTAC, especially the VTAC will be left bundle branch block with poor R rate of progression. You can't necessarily see that in these PVCs, but it is kind of a left bundle branch block PVC. So I don't see any of the precordial leads to really prove to you it's a left bundle. But yeah, our right ventricular, arrhythmogenic right ventricular dysplasia, so we put a defibrillator in her and she had to give up her triathlon, unfortunately. She also got an ablation. She did well. Had a baby, living life normally. All right. So the RV myocardium is replaced by fat cells, basically. It's a genetic condition. It kind of runs in families. The penetration is kind of poor. So, you know, sometimes you'll notice, I had a grandfather who died suddenly in his 20s or 30s, but everybody else is fine. And then somebody's got RV dysplasia, their kids might be fine, and maybe one of the grandchildren might have it or something like that. So it's not very strongly from one person to the next, but it is genetic and familial. The genetics of it are kind of dirty because a lot of the genes for ARVD are all over the place. A lot of people have them that never develop ARVD, or nobody in the family has it. So, so you often see these genes pop up in people that don't have it at all. There's probably a combination of genetic and environmental. We do see it in dramatic endurance events like triathlon and Tour de France kind of cycling type of things, where people spend hours doing endurance events. That seems to be an inducing factor. And it makes ARVD worse if you continue to do that. So we recommend that people don't do extreme endurance training if they have ARVD. We're not saying nobody should do it, but it does seem to be, there are quite a more especially high-level triathletes than you would expect have been diagnosed with ARVD.
Would this be like an MRI diagnosis, or can you see this on echo?
You can sometimes see it on echo. You can see dilated right ventricle, and you can see diverticuli. The MRI diagnosis is a minor criteria because it can overdiagnose it. But yes, you can see it on MRI. You see fatty replacement of the right ventricular free wall. You see diverticula. You see dilation of the right ventricle. Right ventricular dysfunction. The EKG criteria are major criteria. The VTAC is a major criteria. Family history of ARVD by autopsy or by diagnosis is a major criteria. Family history of sudden cardiac death related to ARVD is one of the major criteria.
Did this patient have any RV dysfunction, like symptoms before this
No,
trial?
I mean, like I said.
You said she was having like episodes versus like a strong.
Yes, sometimes if it's really advanced, you can get right ventricular dysfunction. Rarely you can get left ventricular dysfunction too. It can affect the left ventricle, but most of the time, the heart function is fine. It's the arrhythmia that kills you. If it wasn't for the arrhythmia, they'd live long and hearty lives. I think that's it for today. I hope it was worth it. I sort of feel like I'm